People put too much pressure on themselves to create this perfect composite, but you're working in an imperfect mouth. And that's what I always say to everyone, that look, don't look at it to create something beautiful. Look at it from a functional, logical perspective in terms of how you're going to build it back up.
What technique have you found a good balance between efficiency and actually a technique that helps you to, by the way of placement of the composite, to help develop your anatomy?
90% of the time, I don't adjust. Never. I don't polish my composites. Nothing at all. I know that when I've actually built up that composite, because I've followed every single anatomical clue that's present, I rarely have to adjust. Everyone is different. So you've got to respect that. And I think a lot of people become unstuck because they want to create this ideal restoration rather than the restoration for the patient, if that makes sense. My advice is always plan what you're going to do. Take your time. And the fact that you're going to take your time will show the patient that you're actually interested in doing what you want to do properly.
When we make beautiful restorations in composite in the posterior, are we doing it for us or are we doing it for the patient? I think we're doing it for us. Like anyone who uses stain, come on, we're doing it because it's a form of self-satisfying. It's often for the gram. What's important for the patient? Well, efficiency and functionality. So this episode is all about that. My guest, Dr. Vishal Shah, he makes beautiful posterior composites, but his emphasis is on them being functional with proper contact points and being appropriate for that dentition. And this is something that's so bread and butter, a daily posterior composites that we do. And in this episode, we're going to go deep into this topic, from anatomy to sequencing and the all-important matricing. This is a proper clinical discussion on posterior composites. Every episode we have a protrusive dental pearl, and today's pearl is something I've kind of mentioned before several times, especially in our occlusion-based episodes, but it's a great opportunity to give it as an official pearl now. Now, I did mention anatomy, right? The anatomy of your posterior composites. Now, if you've ever been in a scenario where you do a restoration under rubber dam and you take the rubber dam off and you're there for ages deleting all your anatomy, and what looked really beautiful and Instagram worthy now just looks like a pancake. And of course, you're all driving, chopping onions, or on the treadmill and you are nodding for sure. Now, the reason that happens is because we failed to appreciate what is the dental age of the patient's teeth. Yeah, not how old is the patient, is how old are the teeth. How old is the opposing tooth, i.e. think of it as how much wear it has. Because if you're treating an upper molar and there was a flat amalgam there before, and the lower molar has got a very flat amalgam, then I promise you that as soon as you think about making nice cuspal inclines and fissures and mini cusps, secondary and tertiary anatomy, that as soon as the patient bites together, it's not going to be compatible with the opposing tooth. So what is the cure or the hack for that? Well, you need to appreciate the anatomy beforehand. You need to see how much space you have, and then you need to design how old you're going to make this tooth. How well will it fit into the quadrant, and how well will it fit against the opposing tooth? When you take just a moment to think about these concepts before you think about restoring the tooth, you will provide the appropriate anatomy, and therefore you'll be far more efficient. And something that we talk about again in this episode. Our guest today, Vishal, by the way, he's got the best voice ever. I kind of want him to take over the podcast just so I can hear his voice every day. So please enjoy Vishal's voice, and I'll see you in the outro.
Dr. Vishal Shah, welcome to the Protrusive podcast. One thing I want to tell everyone about you, and they don't need to, they'll hear this. Everyone will hear this, and as soon as you open your mouth, they will hear this, right? You know how some people, right, have got, some people like me have got a face for radio, right? You, sir, have got the voice for radio. I tell you every time, mate, you should do the podcast. You have the best, deepest voice ever. So, Vishal, tell us about yourself, where you work, what are you into, man?
So thanks, Jazz. Now you made me a bit conscious about my voice.
It's awesome.
Most of you guys know me. I'm Vishal Shah. I'm a principal dentist. I've got my own practice in Hoddesdon in Hertfordshire. I do general dentistry, mixed dentistry, so NHS and private. A lot of people get quite shocked when I say that, and I'm thinking it's just a run-of-the-mill thing, So yeah, just a passionate guy who loves what he does and wants to do the right thing, Thanks very much for having me on this podcast as well, because I've been watching what you've been doing, and it's great to see what you do to support the community. It's really, really good.
Well, thanks for coming on, Vish, and your cases that you post so regularly, everyday dentistry, it's brilliant. It's such a you make so many topics tangible, and you inspire so many of us. And you're exceptional. You're one of those annoying dentists that just seem to be good at everything, right? You're definitely in that camp from what I'm seeing. And of course, like, your anatomy is just beautiful. Like, we look at your resins and we think, wow, wow, wow. And so I wanted to touch on this subject. So I want to just basically make it very tangible, very clinically led and clinically focused, so we can jump straight into a scenario, which is when you have that patient who's got, MODB, like giant flat amalgam, right? And then we're taught that when you have an amalgam on like the lower left molar, you look at the lower right molar and you look at the anatomy and you try and copy that. However, that tooth is also a PFM which has had the porcelain worn down. Now you can see the metal, right? Everyone has this patient, okay? And therefore you're like, okay, well, I've kind of lost a reference in that regard. And so tell us about how you approach a typical case where you need to replace that restoration. For argument's sake, let's say that it's going to be an interim composite restoration, future crown, but you actually want that composite to serve, 5-10 years, for example, for budget reasons or whatever. How can you now make something for the average hands? Like, you're exceptional, but for the average hands, what principles can you teach us to get some sort of decent looking composite and you're not just recreating a flat white amalgam?
The thing is that what you've actually got to do is you've got to think about what you're doing. You've got to look around the rest of the mouth. Now, you touched earlier on, you're looking at the contralateral tooth. You might, you look at that and you see that there's a porcelain bonded crown. You don't have any reference point, okay? But you've got to bring it down to basics. And we all know that teeth have a certain anatomy, okay? So when I did my learning, I used the PTC chart. Okay, and you can get that on Google and stuff like that, right? So what it does, it shows you the basic primary anatomy, and then it shows you another column of all the secondary anatomy and stuff. Now, for me, that is the basics of everything that I do. And I'm not saying this is the PTC necessarily, but this is just about what we know. Simple things like we know that the lower 6, for example, is going to have 5 cusps. It's got 3 on the buccal, 2 on the lingual. We know that a 7 looks like a hot cross bun. We know that the buccal aspect of the lower premolars is a little bit fatter than the lingual. We know that an upper 6 has, a mesopalatal cusp, which is quite large. So these are the basic things that we've actually got. And all too often what we find is when we look at this case, we immerse ourselves on a micro level, on a more complex level, rather than actually just saying, well, hang on, what's it supposed to look like? Okay, so that's your first guide, where things are going. The second thing I actually do is I look at the entire arch. So you don't necessarily need to look at the other teeth or the contralateral tooth. Look at the arch, see where that central occlusal fissure line is going. And generally most arches, which are fairly well aligned, okay, will actually have that little straightness from the 7 to the 6 and then the 5, and then slowly towards the 4 it starts curving to the main curve towards the front of the mouth as well. So now you've established where your central fissure line is going to be, and everything else gets built up around that. Okay, look at the teeth in front and behind, look at what those cuspal inclinations are. If the cusp on the say, for example, you've got a bruxist, okay, you're not going to give a fully anatomical restoration with really deep fissures. This person's going to have, very, very narrow and shallow fissures as well. So you've got to look at all of these clues. You've got to understand what you're actually doing before doing it. And I think people put too much pressure on themselves to create this perfect composite, but you're working in an imperfect mouth. And that's what I always say to everyone, that look, don't look at it to create something beautiful. Look at it from a functional, logical perspective in terms of how you're going to build it back up.
I think that's a common mistake, that people think of, the PTC sort of diagrams or how many cusps a tooth should have, and then they forget to look at the patient's dentition. So I always say that patient has an age, their sort of chronological, biological age. If someone's 46, they're 46, but their teeth could be 14 or they could be 80. Even though the patient's 46, the patient's teeth could be very young or they could be very old, depending on if they had more physiological wear or pathological wear. It may not be, it's very rare. Well, not very rare, sorry. The patient is 46 years old and the teeth may also look 46 years old. And actually, in that scenario, we still expect them to have somewhat good anatomy. Most of the cuss structure should, maybe a little bit of wear sets here and there, but we still have enough references. But sometimes, even in a 30-year-old patient, a dental age could be 150. There could be interdentine everywhere. And you can't then, in that case, you may need to raise the vertical dimension. You need to look at the opposing tooth and think, okay, where are my cusps? And so the common mistake people make, and which is why the whole joke exists, that when you remove your rubber dam, you're spending half an hour adjusting your composite, is because you have conformed to a textbook and you have not studied the patient's articular system to understand, okay, just like you said, look at the teeth in front and behind. Look at the cuspal inclines. Some people's teeth are cuspier. Some people's are shallower cusps. And if you don't match the patient's arch and the opposing, you're going to run into trouble. The trouble is, though, it's all too easy. And I do it myself. I'm trying to do this like amalgam replacement with a composite, for example. And as soon as you even think about putting any degree of anatomy in, it's going to be proud because what they had before was flat. So how can we still make things a bit more functional or look better without having to just, again, recreate a flat white amalgam, if you like, right? Everything's just recreated because it's very difficult actually to do that. Do you use wax up? Do you use any, like sometimes you can actually put some composite, expired composite on the tooth, get the patient to bite together, okay, where have I got space to build some anatomy, and how important is that? Because some people might say, you know what, as long as it's got a MIP dot and the fissures are a bit like fissure stain, it's for the dentist, not for the patient. So what degree does this hold importance?
So it depends. So for example, like, you said to me that this patient's got a massive MODP amalgam or an MODL amalgam or whatever it is, right? If you're doing it as a precursor to a crown, and we'll talk about this later on, obviously, because one of the things you asked me to speak about was how to make it efficient, right? So you've got to think about what you're going to try and achieve. Now, is an MODL composite going to last for the next 5-10 years? Well, unlikely. You've got to appreciate and respect what the capabilities of your materials are. Affordability doesn't come into it this stage. Of course, we live in a world now where things are harder. Patients are finding it harder to afford quality dentistry and stuff. So you might want to stretch it a little bit, but you've got to think about what you're trying to achieve in the end. Now, if it's a cuspal coverage restoration, I'm not going to spend ages looking at every single nook and cranny. What I'm actually going to do is try and achieve some sort of tripod 3-point contact from the opposing tooth. Okay. Now, what that's going to help with, is it's going to help with maintaining the structural integrity of the tooth, number one. Okay. But number two, it's going to give a little bit of stability where that patient actually is. Because in most cases, what general dentists are doing is conformative dentistry. Reorganization is a totally different game. So when you're actually working in a mouth, which is full of flat amalgams, incorporating just the basic structure, which is like, on a lower 6, you just want to put in those five cusps. You want to make sure that central fissure lines in the correct place. You want to make sure your contact points are correct. And that's basically it. So I allow probably about 20 minutes to build up a core for an MODL, large MODL. Okay. And that includes everything: getting the patient in, numbing them up, rubber dam, taking the, the caries and everything out. I don't even use sectional matrices in these situations. I use a standard Squeveland and just get a restoration in to reinforce that tooth. As and when the patient is ready to have a cuspal coverage restoration, we'll do it then. But they'll very, very quickly realize what you're trying to do as well. So it's funny how it's maybe not lack of affordability, but it's lack of understanding and valuing what we're trying to bring to the table. Basic anatomy is really, really simple. I just put in a little few grooves. I look for any clue in the anatomy that's remaining of the tooth, including, and this is something that loads of people miss out, the outside of the tooth. So if you think about it, right, you've got an MODL composite where the mesiolingual cusp is fractured. That distal cusp incline coming into that central fissure between the mesiolingual and distal lingual cusp has an incline, which you can match onto the other side. Okay. If you've actually just taken time to look at the opposing tooth to see how wide that mesiopalatal cusp is and how that's going to ride through in between in excursive movements, then you have an idea of how wide that incline or that fissure's got to be. You don't want to make it too triangular and small if you've got a massive cusp, because you're going to get an interference, okay? So all you do is you flatten it out and just keep it like that. But there is so much information on a single tooth that you can actually restore. Again, I sort of refer to the PDC concept and, what we're being taught at university on a basic level. But again, teeth are like fingerprints. Everyone's teeth are different. You'll see 7s which have got 5 cusps. They're not all hot cross buns, You'll see 6s which look like hot cross buns. You'll have 8s which have 6 cusps. Everyone is different. So you've got to respect that. And I think a lot of people become unstuck because they want to create this ideal restoration rather than the restoration for the patient, if that makes sense.
I think you raise a good point about efficiency and being pragmatic, because Zach Clara, my friend, used a really good term, our friend, posh core. Sometimes you're doing a posh core, right? Because it is a core for a crown. The future is just, you're able to, rather than using like a paracord material, you're just using resin, normal composite. But I like the efficiency aspect of what you described, because your main function is to remove any caries, get a seal, and get somewhat of a contact point so it's not going to be a food pack, and therefore it's ready to receive a proper cuspal coverage restoration in the future. At that point, as long as you have some sort of occlusal contact and it's not going to be an interference, then that is probably enough for that tooth. What instrument do you like to use
I
to
just use
create
a very,
your
very-
fissure patterns?
It's a combination of things. So a probe, I'll use one of the very, very thin flat plastics. So like the IPCL instrument. So I can use that. I never ever go into sort of the micro anatomical equipment that I use. So, like all the endo files and stuff. You don't need it. You really don't need it. And the way I actually explain it to the patient is that, look, you're going to need a crown on this tooth anyway. There's no point in me charging you what I charge for a full-blown composite restoration, which is going to take me a heck of a lot of time. It's going to be a lot more stress for me for not really that much long-term gain. So I'm going to take 20 minutes to do this, and I'm going to just give you a basic restoration over which this crown is going to go. So as soon as the patient sees that and they appreciate what you're trying to do, and the fact that it's going to save them that little bit of money, I'm not going to charge them as much, obviously, for a core as I am going to do for a fully
You're saving them
anatomically
40
correct.
minutes worth of fees, which is significant, right? It's taking an hour to do a proper job. Let's face it, it's not an easy thing to do. If you're going to do a proper contact point management, if you're going to check the occlusion afterwards, it's going to make a really, the quality of it that you do, it takes time. 45 minutes to an hour, and it makes sense to do something more efficiently, and therefore we're able to charge the patient at a better rate, because they're going to be investing in a crown in the future anyway.
Yeah, I mean, I generally, if it's a class 2, maybe even a class 3 sort of thing, I generally allow half an hour. I don't allow more than that.
Wow.
Okay. And I think that all boils down to, number one, obviously experience. Okay. Because the more you do, the quicker you get. It's like anything, it's that muscle memory and all the rest of it. But it's really, really important. I mean, if we're talking about sort of efficiency, all right, you got to plan what you're going to do. If you go in without a plan, so a lot of the times, I hear loads of dentists, especially the guys who work in the NHS and stuff, right? And they're like, yeah, get the patient in, you do the checkup and you find that the patient's got a fractured cusp or whatever it is, and you just quickly drill it out and put a composite there and then. You haven't had time to analyze, you haven't had time to actually assess the tooth properly. In the time that you're actually taking, generally, when you have patients on the NHS coming in, the 10, 15-minute checkup sort of thing, right? It just never works, right? So my advice is always plan what you're going to do, take your time. And the fact that you're going to take your time will show the patient that you're actually interested in doing what you want to do properly. If it's rushed and they have a problem or the occlusion is high, that's all down to you, to be fair. Understand why you're doing what you're doing. A lot of people, will say to a patient, look, you need a crown. Well, I can't afford it. Okay, fine. Well, let's put in a composite. It's like, well, hang on. You're shooting yourself in the foot. Visualize what you want to achieve. Train your team, train your nurse, understand what the,
So
get them to
let's
understand.
just touch on that because I want to skip over. There's 2 points we need to just touch on before we continue.
Sure.
One is that scenario where if the patient says, "Oh, I can't afford a crown," and then you do the composite, what should we be doing in that scenario? Is it again going back to doing a more basic 20-minute core, posh core, like we said? Is that what you mean?
Yeah, I mean, generally, I wouldn't allow that much more time because it's not the right treatment as such. All we're doing is we're stabilizing the tooth, ready for its final and definitive restoration. So I don't spend that much time on it, okay? Generally, it's the best way to do it because it serves the patient, it restores the function temporarily. It might not be perfect, but it gets the patient through that one initial phase to then move on to the next one.
It stabilizes the situation. And then, so the other thing to touch on is, you said a class 2, class 3 will take you half an hour. But the specific scenario I was talking about is, I was trying to make this distinction between you spending 20 minutes to do a posh core versus spending an hour on that particular tooth, because I'm genuinely interested, because I know you're very efficient. So let's say you have a lower left molar. It is an MOD L amalgam, and let's say you are going to give your Vishal's finest composite, reproduce the fissure stain, get the endophile out, get the staining. In that scenario, removal of amalgam, caries clearance, caries dye, all that kind of stuff, build up the sectional matrix potentially, okay, and build up. How long would that proper appointment take, and therefore how much time are you saving the patient, because this patient needs a crown anyway? But if you were to give it a proper whack, how long would it take?
I'd probably be looking at allowing maximum 45 minutes. Not much more longer than that. And the reason for that basically is because I've trained my nurse, I've trained the team around it and stuff like that. I've got everything out, I know exactly what I've done visually and sort of psychologically. I've already train myself to be in a position to execute this with efficiency. So one of the most important things I always say, and this is a common known fact, it's not something that I've invented, is they always say, build up your proximal walls. Okay, get your contact points there, because anatomy is not only about what you see from the occlusal aspect, it's also what you see from, your contact points, the proximal portions of the teeth as well. Judge where you're going to put those contact points. It's so, so important. If you've got a patient who's got really large black triangles, they've got constant food backing, might be the reason for the caries in the first place, sort of thing, then you've got to think about where you're going to manipulate that contact or how wide you might make it. Now, some people say, contact points should be like 2 tennis balls touching. It's just an area. It's called a point. But sometimes it's necessary to put a contact area. It's a little bit of a gray area. It's a little bit where people think, ooh, I don't know about that. But it's worked well for me. And I look at things more from a practical perspective. I'm not an academic, I'm a practical guy. I want to do things that work. And these things have worked in my hands quite well. So once I've built up the proximal walls, then all I've got is an occlusal aspect to build up. Now, say, for example, it's an MOD amalgam. This is the classic one, right? Massive MOD amalgam. Mesiolingual cusp is broken off or distal lingual cusp is broken off. In those cases, what I tend to do is I build up just with some composite, okay, just some paste composite, no etch, no nothing, stick it onto the tooth, build it up, get the patient to bite down and then cure it, okay? I can then take a little putty sort of stent of it. Okay, I'll make a little putty one. Now, there's a few different ways of doing it. I like doing it just intraorally without a rubber dam. And the reason is that if you do it with the rubber dam in place, number one, you don't have enough space for that sulcus. But number two, you actually get your putty sticking to the dam. It's really horribly messy and it just puts you off. I like working in a clean environment, in a nice organized area, if that makes sense. And then once I've put the rubber dam on and I've done my cavity prep and all the rest of it, then I actually put the stent and visually first look at it, then actually trim it accordingly because the rubber dam is going to be in some of the way. You're not going to engage the full sulcus, and then do that. Inside that, I put an outer shell, like we build up palatal shells on anteriors and stuff. I'll put a shell of composite there, stick it up against the side of the tooth, cure that, and now I've got my mesiolingual cusp.
So this is like a lingual stent, isn't it? It's a lingual putty stent for that scenario that you described. And then thereafter, you're able to do let's say a sectional matrix thereafter. Then you do the proximal wall, yeah?
Yeah, correct. And sometimes a lot of people say, right, okay, fine. So if you've got your mesial sort of box cut and it's the entire lingual cusp, how far do you extend it? Does this make sense? So you got the lingual cusp, the mesiolingual cusp. There's the mesial aspect there. So how far do you extend that stent? And I say extend it as far as your sectional matrix will stretch round. So you don't have to go into that contact point, into that embrasure proximally, because you can control that later. By putting a stent on, you can't control where that composite's going to flow out. So go short of it because your matrix will cover the rest of it.
So basically what you're trying to say is your putty stent is there literally just to build the lingual anatomy. It doesn't have to also build your contact. Let the matrix build a contact for you. Don't steal the space of your matrix. Steal the role of the matrix.
Absolutely, yeah. That's the most important part, right? Because you get food backing and it doesn't matter how good your lingual wall looks if your restoration's failed. So
Vishal, you're about efficiency, right? And so I like these little tips you've given. I want to just find out is two things. What matrices do you use, right? Because I feel like you're someone who's a proper geek. You've been around the block, and everyone's got their favorite matrices. And so I honor the fact that everyone's different, but it's nice to say, okay, well, what does Vishal use in 2025? It might be different next year. It might be different 3 years ago. Do you believe there's one matrix that is superior, and then that's what you use for every single type of restoration? Or are you someone who stocks 4 or 5 different things, and you know, okay, in this kind of scenario, I'm going to reach for that matrix? How does your mind think when it comes to matricing?
Very simple. I just keep it simple.
Hello, YouTube Protrusive. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour
of the entire network. Now, in terms of where the magic happens, that's in the protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I want to do is create a really supportive environment that's not like the environment we have on Facebook, and is built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz, like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at it, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive Guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you do make an account on Android, iOS. If you make it on the website, you get access to the free trial, and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description, and thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode.
It's literally keep it simple. I used all of them, and they've all got their goods and their bads, but the one that for me universally does the job is the V3 system, the Balodent. It is phenomenal. Loads of different features of that. Number one, it's metal, so it's quite rigid. It's strong. Okay, it's not as rigid as the Garrison matrices. Now, I find the Garrison ones are a little bit too thick. Okay. And then you've got your BioClear ones. I mean, there's loads of different connotations, but the main three are sort of your Garrison, your Balodent, and your BioClear ones, right? The BioClear, I have a problem with because, yes, it's transparent, but it's made out of plastic. For plastic to be strong, it's got to have a certain amount of thickness. I never pre-wedge. I don't do anything like that because what you're doing when you're pre-wedging is basically you're stretching up the ligaments to move the tooth slightly, right? To create that space. I don't do that. I never, ever pre-wedge because you don't know how far back your tooth's going to bounce. And if you've actually over-contoured, like if you've made it too wide, then technically you've left the tooth in a position where the ligaments are permanently stretched. Okay. Now it could cause a little bit of tooth movement and rejigging and all the rest of it, but you don't need to do that. It all boils down then to cavity prep. You know, I say, look, clear your contact. If you're actually going to place a matrix and you're going to rebuild it, how about you actually clear your contact and prepare your cavity in such a way that when you've actually built up that proximal wall, your excess flush of composite is going to be where you can actually reach with a disc. So flare out your cavity margins. You know, the tooth needs restoration anyway.
It's so much easier to get a soft Lexus on the lingual or the buccal than to try and get it into the embrasure. And you're totally right. To try and direct it, you're going to get excess, but we try and do it so that you influence where that excess goes. So it makes it strategic and easier for us to clean up. Absolutely.
Absolutely. And not only that, the other thing that's beautiful about the Balodent one, especially when you've got these really deep margins and stuff, okay, when you've cured your proximal wall, you don't get an absolute 100% cure of the composite. So by the time you actually remove your matrix, okay, and this is the other good thing about the Palladin ones, they've got these little sort of holes in the matrices where you can actually just engage your tweezers and pull them out. Okay, it's fantastic. But at the point at which that you pull that out, the composite that's around the base of your cavity, a lot of people get these little overhangs there because the wedge might not be wide enough or whatever it is. Or that, you know, the space might be too big for any size of wedge, and that's a whole different topic sort of thing. But you can actually slide in a size 12 scalpel. And because the composite's not fully cured, it's almost like taking a little strip out of wax with a really sharp knife. It just comes away so beautifully, you know, and you don't have to worry about the finishing then proximally at all. So for me, the Palladin is just the best of all the worlds. Now, the Palladin as a system I use routinely, okay? The very, very odd occasion I will change my clamp that actually clamps the matrix and, you know, pushes it up against the tooth, okay? The Garrison clamps are really, really good. They have those anatomical sort of teeth that go in, but you've got to be careful of that as well, because sometimes it narrows the tooth. And teeth sort of, you know, from the proximal contact point, they sort of widen and come out before it comes back in to the sort of outer anatomy of the tooth. So you've got to be a little bit careful with the Garrisons there.
Explain that in a different way. I couldn't follow along there. Make that tangible. What do you mean when you said that?
Okay, so imagine you've got a molar which is that wide, okay?
So yeah, for the listeners, it's like a very wide cavity, yeah?
A wide cavity, a wide molar, okay? And also you've lost some of, let's talk about just, we're restoring the distal wall, okay? The distal proximal wall. Now, if you've lost some of that distal surface, say for example, you know, you've got the large flared amalgams, right? So if you've got that and you use a Garrison clamp, because anatomically the teeth actually create
Clamp or
a
matrix?
curve. Sorry?
You said clamp. Garrison clamp or Garrison matrix?
Clamp itself.
Okay, this is okay. I need to get my clamp to me is rubber dam. Do you mean the ring?
The ring.
Okay,
Yeah,
got you. The
I
ring.
call it
Okay.
the clamp. Sorry. Yeah. So with the ring, they've got the teeth. Okay, one side of that tooth engages on the mesial aspect of the 7,
Okay.
and the other on the other side of that tooth, you've actually got the rest where it's engaging your matrix.
Yes.
Sometimes that curvature is too narrow, especially on the Garrisons, okay? It doesn't sort of give you that ability to develop the flaring out of the actual tooth. And this is why I love the ring from Palladin, because it doesn't have any teeth. There's space there. So what you can actually do is with an instrument, you can hold on to your matrix, you can pull it on one side and tweak it and actually just round it out. And as it rounds out, sometimes it will square out because it is metal at the end of the day. But as you do it, you make that sort of squared portion in an area where you can access, which you can disc later. So the Garrison clamps, the rings that I use will only be in a situation if my cavity is very, very narrow. I've already engaged that curvature into the proximal surface rather than something where I'm building the entire proximal surface.
Okay, got it. Perfect. I'll be able to
Make sense?
supplement some diagrams for that as well. But that makes sense now.
Hey, Protrusive, Jazz interjecting here just to make sure everything is crystal clear and everything is tangible. It can get really confusing talking about embrasure shapes and the influence of different matrix systems. Never fear, Uncle Jazz is here. Let me explain. Now, I'm being a little bit brave here because I was thinking about moving this purely to video form, so YouTube or Protrusive Guidance app, but our listeners, right? Those of you who are going for a jog somewhere or on a train or driving, I still want you to gain from this. So whilst I do have a video in the background image and I'm kind of explaining over it and you can reference that later, for those of you who are listening, I will describe what I'm seeing for you. So, embrasures are like the V-shaped valleys that are made as we move away from the contact point, let's say between two molars. Where the teeth touch is the contact point, yeah, the two molars, upper molars, let's say, where they touch is the contact point or contact area. And as the tooth structure curves away from the contact point, all that negative space is the embrasure. And so we would have a buccal embrasure, which is the negative space buccally, and we have a lingual or palatal embrasure as well. So for upper molars, the palatal embrasure, the dead space, that V-shaped valley, is wider than the buccal, right? So palatal is wider than buccal. This is why Garrison have a quad matrix, right? It's got this ring which is wider palatally and narrower buccally, kind of match what teeth exhibit. And they got these for like all 4 quadrants, hence the name quad matrix. Now let's talk pros and cons, because the video I found was on TikTok and it was actually made by Garrison. Garrison made this video. It was actually comparing the Garrison quad ring versus the Palodent ring. And Garrison was saying that their ring is better, obviously. And from what Dr. Vishal describes, and I'll explain as well, is that the ring has a buccal and palatal portion which extends a lot deeper into the embrasure. There's more of it contacting the matrix, buccal and palatal. There's less likely to be flash because of this very intimate contact between the ring and the matrix. So Garrison would say, hey, this is a really good thing. Our ring is better. And so you would get less flash and you'd get a more defined shape guided by the ring. That's for sure. But Dr. Vishal, our guest, argued that a consideration here, or a disadvantage, is that A, it may give you an embrasure that's too wide, it's too big, and that could cause food packing issues. We've all picked sandwich and bread and food out of patients' buccal embrasures before while doing a periodontal charting, for example. Yeah, that one. Those huge buccal embrasures sometimes can be a problem. Sometimes we want to make them narrow when we're restoring the teeth. And so with a system like the Garrison, it's unforgiving. It's not very adaptable. Thou shalt have a wide embrasure. And so the Garrison ring really dictates the embrasure shape you get. And that's fine. But our guest, Dr. Vishal, argued that he prefers the Palodent more. And I'm so glad Garrison made this comparison video, so thanks so much to Garrison. And so what I'm showing here for those audio listeners is now the Palodent ring doesn't have these teeth that extend into an embrasure. It does not have any extension into this embrasure space. And so Garrison would argue that actually this is bad because you're going to get more flash, potentially, because you won't have a tight seal of the matrix in those areas. But our guest, Dr. Vishal Shah, argues that he likes this because it gives you freedom. You can then manipulate the matrix to create a narrower embrasure on purpose so you get less food packing, for example. But generally, to give you all this room in the buccal embrasure and in the platal embrasure to allow you to use PTFE or your instrument, and gives you wiggle room for your matrix to flare out some more, or to be able to define the shape of the embrasure as you want it, not being forced by the ring system itself. So I hope that made sense for the audio listeners. For those watching, there we have it. Palodent does not have the teeth that goes into the embrasure space, thus giving you the control of the embrasure and potentially avoiding or preventing an embrasure that's too wide and trapping food, versus the Garrison quad ring, which gives you a very beautiful shape, but you are stuck with that shape. And the potential criticism is that it allows too much food trapping. Not in between the teeth because you'll get a tight contact, but in the embrasure areas. So I pitch it to you guys. Are you team Garrison or are you team Palodent? Comment below, let us know.
Okay, so tell me now, Vish, about different techniques of actually building composite up. That's the espresso technique and like, injection overmolding technique. When I see one of your beautiful composites that you do, what technique have you found a good balance between efficiency and actually a technique that helps you to, by the way of placement of the composite, to help develop your anatomy? For example, I'm a cusp by cusp kind of guy. I feel I can get a reasonably good anatomy. I feel like I'm sacrificing a little bit on efficiency that way, and so sometimes I'm tempted to change. But I would love to know what you recommend and what you teach in terms of what is a good balance between efficient and actually getting the right anatomy in the build-up technique.
So, as I said, the first thing that you're actually doing is you're making sure your proximal walls are correct, okay? The way I actually do that is when I build up my proximal wall, I add composite down at the base and I use a micro brush to push it. So you're pushing apically and towards the tooth against which you're actually restoring. So if you're restoring an MO on a 6, on that mesial proximal wall, I'll place the composite and then with a micro brush, I'll actually squeeze it downwards, which will mean that some of the composite will lift up. I'll add a bit more composite, squeeze it again, and then all of a sudden it starts slumping over the top on the marginal ridge portion. That's what gives you your curve.
Nice.
Okay, so by squeezing at the bottom, and you don't have to do it in one sort of hit, you can actually pack your composite down, push it against the wall, maybe even use a bit of flowable if you've got like very, very sort of fine areas where your base composite might not get to, so that you don't have airflow, voids and stuff, right? So once you've actually done that, then use your micro brush, and generally you want to make it about 2 millimeters wide, 1.5 to 2 millimeters, okay? But once you've got that amount there, Then you push your microbrush down into the base of the cavity, and all that happens is the top bit of the composite is unsupported. So it slumps, but it slumps in a curve. Okay? As soon as that's done, I get my microbrush on the top, I smooth it against the other cusps or the remaining anatomy, and I cure it. There's a full 20-second cure in that situation.
And you said 2 millimeters. That's like 2 millimeters width in terms of from the like the proximal, actually the thickness of the proximal wall that you're building, right?
Correct.
Okay.
Yeah. Sometimes 2 millimeters can be a little bit too big, so you've got to see, look at the tooth, the
Like
tooth
maybe for a
either side.
premolar, it might be like a millimeter, maybe.
Yeah, absolutely. But it's got to have enough space there to be able to get that marginal ridge. That's what I look for. I look for that curve, and is it consistent with the rest of the tooth? Okay.
That's a good one, because I've heard about composite allowing it to sort of slump in your favor, allowing the features, the physical features of the composite as you place it to help you and aid you in anatomy. But I didn't really consider it for the proximal wall itself, and it makes a lot of sense. If you pack it against the matrix in the cervical seal area and allow the more coronal bit to slump in, because that's the most difficult bit. The most common mistake people make is that they make their make the wall too straight, and they don't. It lacks that. What the best way to describe it? It lacks that line angle that comes inwards. It lacks the form that comes more towards the middle of the tooth.
Yeah, and this is why I love the Paladin matrix, because it actually has that little bit of shape in it. So as you're actually pushing with your microbrush down, the matrix actually guides the composite in that shape. It's beautiful. I think it is the most underrated matrix. I mean, there's so many out there, but this is one of the originals, and they really thought about this well. Might have been a fluke even, but that's how things work. It's fantastic. I love it. I'm a real geek about it. So once that's actually done, it's a 20-second cure. I make sure it's nicely polymerized, and then I actually put my base layer in.
Do you remove the matrix at this point? This is like a personal preference, or do you just keep it on?
It depends, okay? So if I'm not confident that I've got a full seal or whatever it is, or the base I might have actually compacted a bit too much, then I'll leave the matrix in. But once I put that base layer in, I cure that for 20 seconds. Now, the base layer is really, really, really important. And a lot of people don't realize this, because you want a nice flat bed onto which to build your cusps onto, right? So once I put my base layer on, I look at the teeth either side. And the reason why I do that is because it's often very difficult to assess how high or low this base layer should be. Okay? And what I do is I look at the teeth on either side, and I see what is the deepest point of the fissure system in that tooth. And that's the level to which I build my base layer.
And the base layer is like flowable, or is it paste composite?
Always paste. If I've got lots of different undulations and stuff like that, the cavity, floor is not smooth enough and stuff like that, I might use a little bit of flowable, but this is literally just like dots of it. I don't like using flowable composite on the base, okay? I use OptiBond FL, the bonding agent has got filler particles in it. That's good enough for me.
Yep.
Once that base layer is placed, I then, with my endo file, just outline and mark where I want to build up all my cusps. Okay, so I've got my guide. First thing I draw is the central occlusal line. Okay, the central fissure of the tooth, and that's by looking at the teeth either side and I never isolate one tooth or one tooth either side. I always try to isolate the whole quadrant. Okay, so this is preempted. I'll just look at the teeth first. I'll say, right, how much information can I get? And the more teeth I've got, the more information I can get from, that perspective. So once that's done, I draw that central fissure line. I draw the different sort of cusp lines as well. And it's very, very rough. Okay, it's just like an indent. It's not a gouging out. And then I cure that for 20 seconds. Okay, so now I know that my proximal wall's done. My base layer is done. I remove the matrix, wedge stays in. Once that's actually done, I've now just got a class 1 restoration to deal with. I always start with the most difficult cusp.
So the base layer is a predefined thickness that you usually aim for?
No, it's just up to the deepest fissure on
bit.
either two.
And there's no concerns about here, like, some people may be thinking, what about the C factor? You've literally bonded to the buccal wall, the distal mesial wall, and the lingual wall. Have you got any concerns about bonding those at the same time? Because some people say, let's do cusp by cusp so that we avoid that kind of shrinkage stress. What do you think about that?
I mean, there's definitely evidence for it, otherwise it wouldn't be out, okay? But it's never I've never had it affect what I'm doing. I mean, I'm
That's all I
now
wanted to hear,
starting.
mate. I wanted to hear that from thousands of restorations. It's all good, because that sounds an efficient and a good way. I just wanted you all to be like, mate, just say, mate, it's absolutely fine. Don't worry.
Yeah, I literally no, it doesn't bother me. It doesn't
Good.
bother me at all.
Me neither.
Because that's just too far scientific, and
Mm-mm.
we're not in that environment. We're in a compromise anyway. Okay.
Yep.
So once I've built up that base layer, I always start with the most difficult cusp, or the one that I think is going to be the most stressful. Okay. And the reason for that is, if we leave that till last, that is where we've got to have the most stress, the most concentration. And by this point, we're getting a little bit worn out. So you might just rush it. You might just get it slightly wrong. The other thing I might even do is say, okay, fine, where have I got the most guidance? Which portion of the tooth has got the most anatomy left that I can recreate? And then against that and off of that, follow through with the rest of the restoration. So there's two sides, okay? It's never a rule. Do what feels the most comfortable first. But I always say, try and eat the frog, because if you get the most difficult bit out of the way, then that's done. And if you nail it, you get a bit of motivation. There's almost like an adrenaline rush, that you get in, and then your restoration comes out really, really well. But if you leave that last cusp till the very end, you think, oh, man, this is just, no, I'm just going to get it done. I guarantee you, when you take off that rubber dam, you're going to be adjusting your composite. Now, 90% of the time, I don't adjust. Never. I don't polish my composites. Nothing at all. I know that when I've actually built up that composite, because I've followed every single anatomical clue that's present, I rarely have to adjust. A lot of people don't believe it, but I rarely adjust.
I mean, that's great. And I think the biggest takeaway for me, and like at the moment I'm doing cusp by cusp, and I know I've been taught like espresso technique and all that kind of stuff, but cusp by cusp just made the most sense to me. But I really like this base layer concept of getting the height up to the minimum height. Okay, so the deepest point, and then drawing the fissure line. It makes sense. And then you're doing like a millimeter here, 2 millimeters here, depending on the rise and fall, and the highest points depending on the peaks. And this makes a lot of sense to me. I'm gonna give this a go. But mate, we've just barely scratched the surface today, right? And I think I just wanted to just get you on to talk about how to think about these scenarios. And I think the big takeaway there was, look at the outside of tooth, look at the buccal groove, look at the slopes, consider a palatal or a lingual putty. Or different matrices that you're using, efficiency protocols, you doing the posh core. So we unpacked a lot of value today. And for me, the best bit was the base layer and how I'm going to implement that. So I'll keep everyone updated on how I go in my next case. But, you teach on this subject. You are someone who, is just doing wonderful things. Tell us more about how we can learn from you, Vish.
Just honestly, just keep it simple. Just logically execute your thought process. Always think about what you want to achieve and why you want to achieve it. Dentistry becomes, I don't go out there thinking, right, I'm going to make this absolutely stunning composite. I never ever think of it like that. The stains and stuff is just there. Yeah, it's for me. Okay. No patient's really going to appreciate it. But the thing is that if it's anatomically correct, it's going to look beautiful. It's like, it's like the whole idea of cosmetic dentistry. I don't really believe in it, because if you do your work well, if the form is there, if everything is there where it's supposed to be, it's going to look beautiful. You don't have to emphasize it's going to be cosmetic. It's not. It's just you've reinstated what it was supposed to be as nature intended it to be. So my sort of advice is, don't overthink it. Just simplify it and break it down into logical steps and execute it in that very same logical manner. Don't try and outdo yourself. Just follow what's there and follow what the patient's giving you. There's so much information there.
But how can we reach out to you to learn more, mate? Tell us about your courses, website.
Yeah, so obviously I run the Level Up Dentistry course. So the first one is actually which has been running for over a year and a bit now. And that's the Demystifying Posterior Composites. So it's a 2-day course, 19 and a half hours. So it's intense. Majority of it's hands-on, okay? So Saturday morning, we do all the theoretical side of it. And after that morning, there is no more theory. It's all hands-on. Next year, I'm really, really excited about this, because we're launching a few others as well. So we're going to do some stuff on indirect restorations, both anterior and posterior. We'll be bringing in some anterior composite stuff. I'm going to be working with someone who's actually been on your podcast before, but I'll leave that for later. So it's going to be,
I'm guessing Rusty. Is it Rustum? I'm guessing Rustum.
Probably there, yeah. So, it's really exciting times because, I really, really admire what you've done, because what you want to do is actually share knowledge with people. And it's exactly where I come from. It's not about showing people how good I am. It's about giving people the realization of how good they can be. And if I can do it, believe me, anyone can.
Amazing. Vish, there's a bit where you have to give the website.
Yes. It's www.levelupdentistry.com. I'm not used to promoting myself, so
I know, I can tell. I asked you the first time, you just gave lessons, and then the second time, okay, I'll put the links in the show notes. Thank you so much for sharing wisdom and sharing your cases so generously online and inspiring us to be better every day. Thank you for sharing your voice on the podcast. Once again, it was great to finally host you, and I'm sure I'll catch you out in the CE circuit around. I appreciate your time, my friend.
No, thank you very much, Jazz, and keep doing what you're doing, mate. There's a lot of people who are proud of you, and a lot of respect for what you're doing, mate. Well done, and thanks
so
for
much.
having me.
Appreciate it, buddy. Thank you so much.
All
buddy.
the very best, bud.
So there we have it, guys. Thank you so much for listening to me and, of course, Vishal and his lovely deep voice all the way to the end. This episode is eligible for CPD and CE credits. We are a PACE-approved education provider. The way to do it is head over to the app. That's www.protrusive.app. When you're signed in and watching the premium version of this episode, complete with the full notes and everything, you scroll down to that episode, you answer the quiz, get 80%, and our CPD queen, Marie, will send you a certificate. If you're not yet a premium member and you listen to most of our episodes, then you are leaving CE and CPD on the table. There's excellent value in you becoming a member of Protrusive, not to mention all the different courses and masterclasses we have on there, our ever popular clinical walkthroughs. They are my personal favorite. Just last week, I did a full walkthrough on Icon resin infiltration case. So many of you joined us live for that webinar, and then it's available for replay in the clinical walkthrough section. And if you really love Protrusive, every episode we've ever done, every piece of content we've ever made, whether it's one of our courses that we have, like proper meaty courses, everything is in our AI. You can chat with all of our content, whether you need a quick reference, an idea, or how would this specific guest handle this situation. The moment our AI Ask Jazz answers 6,000 questions every month and growing. So it's certainly become a very popular feature of our subscription. All the different plans and what's inside is available on protrusive.app, and please do sign up via the website and not via iOS. And when you do sign up via the website, you can use your login credentials on the iOS app. So once again, it's www.protrusive.app. For those who are new to the podcast, thanks for listening to this one. Appreciate it. Please do come back and hit that subscribe button, and you've officially become a Protruserati. I'll catch all of you at the same time, same place next week. Bye for now.